computer.
I stopped it for a second. I'll be bringing it right back up.
Okay.
Do you see my blank screen?
Yes.
Okay.
Okay, cool. Okay, well, thank you all for coming to our talk, hosted by the Science Policy Institute and PhD Plus. So this is our third talk in our series on past, present, and future of science-based racial inequities. And this talk is given by Dr. Monica Hooper. It's entitled "The Role of Science in Advancing Health Equity." For those of you who don't know, Dr. Hooper is the Deputy Director of the National Institute on Minority Health and Health Disparities. She's an internationally recognized translational behavior scientist and clinical health psychologist, and she's dedicated her career to the scientific study of minority health and racial ethnic disparities, focusing on chronic illness prevention and health behavior change. So she completed her doctorate in clinical psychology from the University of South Florida and her Bachelor of Science from the University of Miami, as well as an internship in medical psychology from the University of Florida Health Sciences Center. And we're very happy to have her today. And it was really nice of her to show up. She came on recommendation from the NIH director, Francis Collins, which was really cool. And I really appreciate you being able to talk and also allowing us to record this for any other students who might be interested in hearing from this and who aren't able to attend.
Absolutely. Well, thank you very much, Robert, for that really kind introduction, and thanks to the group for inviting me. I did appreciate that Dr. Collins, our NIH director, referred you to me, given that he is immensely busy, and it's hard to imagine being busier than I am, but he's immensely busy dealing with the pandemic and the science response. So I'm delighted to be the stand-in and be here with you today. You know, we are at an interesting, challenging, and unprecedented time in US history. And it's one in which people are discussing social change and health disparities more than we have in the past. And that includes change within the domain of science and how we can advance health equity. So that vision for positive change in science and in healthcare is why I do the work that I do and why NIMHD is such a needed institute at NIH. And we're actually proud to be celebrating our 10th year as an institute. And we are young, we're a small institute, but we are really mighty. And I'd say never has our science, which is in service to communities, been more visible and important for the health of all populations in the United States. So I think as your group, the Science Policy Initiative at UVA, graduate students, I understand, interested in learning more about science and policy and pursuing careers in science policy after graduation, I will leave the hardest part of this work to you. That is, I'll challenge you, charge you with thinking about what I'm about to share and formulating, you know, as individuals and as a collective, thinking about the challenges related to health disparities and minority health science, and to plan and execute science with the potential to make a real impact. And I'll also just challenge you as humans, as individuals, scientists, leaders, people with the power to make things happen within your multiple domains of influence, and to think critically about the path forward and where things are going to go from here. So here is an outline of what I hope to accomplish during this presentation today. And that is to talk a bit about COVID-19, because we must always, at this point, discuss the pandemic. And it's completely related to health disparities. And I think Robert gave me a little sense of the talks that have come before this one. So I think this will complement the things that you've been talking about. And I'm going to be taking this from more of a national perspective and thinking about health disparities and policy and legislation and how NIH supports the science to reduce health disparities in COVID-19 and really beyond. So these are recent data on the novel coronavirus, which is our global pandemic, and its most severe presentation is lower respiratory involvement, leading to severe complications and death. So this is where we are with cases as of yesterday, and we expect, unfortunately, that deaths will. Actually, I just saw a story this morning, but I didn't have time to update the slides. That we have exceeded now 200,000 people having lost their lives from a preventable illness. And we know that patients with comorbidities have more deteriorating outcomes compared to patients without them. So COVID-19 patients with a history of hypertension, obesity, chronic lung disease, diabetes, cardiovascular disease, and others have the worst prognosis and most often end up with complicating outcomes such as pneumonia. And these patients are not only at risk for contracting the virus, but there is a significantly increased risk of death. And older adults account for about a quarter of COVID-19 mortality, and males are also more likely to pass away compared to females. The numbers among younger people and mortality among younger people and significant morbidity, unfortunately, are starting to increase. There's also consistent evidence of a disproportionate COVID-19 impact on specific communities, including racial and ethnic minorities, and within settings such as nursing homes and prisons. And there's also emerging data on disparities in access for COVID-19 testing. So the science response, which is what NIH is working on, is critical for advancements in knowledge, for providing critical data needed to slow the spread and reduce mortality in extra vulnerable communities, and so that resources can be delivered quickly and effectively. So just a couple of examples. Nationally, New York City has been an epicenter. It was when the pandemic really started to heat up. And nationally, since that time, Latinos, Hispanics test positive for coronavirus at rates higher than what would be expected for their share of the population. And these figures showed the disparities in New York City from March through yesterday. Both Latinos and African Americans are facing undue burden in New York compared to all other racial groups. And cases and deaths are greatest in these two populations, with the greatest burden among Latinos. And there are fewer data available on COVID-19 disparities among other populations such as Native Hawaiians and Pacific Islanders. These figures are from May. I believe they were in May, and they show disparities in California by age group and race ethnicity. And Native Hawaiians and Pacific Islanders between the ages of 50 and 64 have substantially greater rates of COVID-19 compared to all other groups. And for adults who are age 80 and older, cases are greatest among African American individuals and are also markedly greater among Hispanics. But as you can see, racial ethnic minority groups in general have substantially more cases per 100 persons in the population in California compared to whites. So these figures show COVID-19 cases and death in Virginia. So what you can see is that African Americans represent 19.9% of the population, yet are 26% of COVID cases and 27% of deaths. In addition, Hispanic Latinos are only 9.8% of the population, but are 31% of cases. And this shows undue burden in these two groups in particular. We also know, many people are concerned about the virus, not wanting to leave home, worried about transmission. And some people are avoiding going to see their doctor, which can have a major health impact. And so the yellow highlights, or orange yellow, they indicate comparisons to whites that are significant at the less than 0.05 level. So these data show that Latinos and African Americans are more likely compared to white individuals to delay or to avoid urgent medical care. And Latinos are more likely to avoid any medical care due to concerns about the virus and its significant numbers. This is very problematic. It suggests that even if a person is not well, they're not likely to see, they may be less likely to see a medical provider. So why are the data pointing to these differences? Such differences by race and ethnicity are known as health disparities. So let's start at the beginning. Why is it important to study health disparities? And the desire to bring these issues to the discussion, to the table, I think is why I was invited by Robert and referred by Dr. Collins to speak about this. And, we have had significant scientific medical advances that have prevented, cured diseases. They've helped change behavior. They've helped extend longevity. But not all populations have benefited from these advancements. And so the initial step is understanding what disparities are, what health disparities are, and the contributing factors, and then interventions that reduce and ultimately eliminate them. So since it's a small group, how many people are on the call? Is there 10 or so people?
There's like 15.
Okay, so since we have a relatively small group, I'm interested in hearing from you, which makes this good. So I'd like to have you think about the question that I just posed and think about the factors that contribute to health disparities. What do you think they are? So I'd like to brainstorm a little bit. I don't know if I can actually see the chat with my presentation mode here, because what I'm interested in knowing is, if we brainstorm everything that just comes to mind that you think may be a contributing factor. So why don't we instead have you just unmute and share with us your thoughts about why health disparities exist? We'll maybe just take a couple of people. Anyone?
This is Karen Skeen. I'll go.
Okay.
I think health disparities are those differences in health that are related to social determinants of health. So they're preventable if we had equitable social determinants.
Thank you. I appreciate that. Thank you. Other ideas?
Hi, Carter Head here. I think one of the big factors here is a lack of trust by certain communities towards the medical community, and it's given as a significant historical inequities and discrimination and abuse of power by the medical community that's really eroded trust in some of these minority communities.
Mm-hmm. Trust is a major problem, and it's an underappreciated social determinant of health. Maybe one more person with thoughts on this? Factors that contribute. Yeah, please.
I'm Kristen Freed. I think that cost of healthcare is actually another important determinant of whether or not people go to the doctor in the first place.
That's true.
Or poorer.
That's true. I mean, I think certainly, even people who have insurance, the co-pays can add up, emergency room visits can add up. And so certainly, people will delay or wait and see if they should go to a doctor or go to a hospital. Particularly, you're right, if finances are an issue, you might wait and see and just maybe go lay down and hope that you feel better instead of pursuing going to see a doctor. So great. Okay, so we will continue the conversation, but it's good to get you, so I kind of understand a little bit about where you're coming from and maybe what the group thinks about these topics, because not everyone agrees, I think, on the contributing factors to health disparities. And there's a couple things that I do want to point out about this. So I want to move into a couple of definitions just as we go further into the conversation. So I'm going to offer you a few definitions. The first one is population differences. So when we talk about population differences, these refer to differences between population groups, maybe the prevalence, and the key about population differences is they're linked to genetics or biology or even geographic location. So sort of gene-environment interactions translate into differences in disease susceptibility. So a few examples here of population differences might be sex differences in color blindness, or the greater prevalence of sickle cell anemia among Americans of African descent, or individuals of Mediterranean heritage. Those are good examples of population differences. Now that's in contrast to health disparities, which are a type of difference. Disparity as a word just means difference, but when you add the word health in front of it, it becomes a very particular type of health difference. And in this case, instead of genetics, the linkage is disadvantage, multiple levels, such as social, economic, environmental. And if you look across the populations who experience health disparities, these are those that have systematically faced greater obstacles to optimal health, and they can be characterized in a number of ways. So race ethnicity is one way, and that's the way that we started this work in health disparities thinking about this, but it's also much broader than that. Socioeconomic status, gender, sexual orientation, and other groups that are often discriminated against or excluded. So health equity is a term that is often used interchangeably with health disparities, but I like to clarify it because it has a distinct meaning. Health equity is the aspiration. It is the highest level of health for all people. To achieve health equity requires that we close the gaps. The gaps are the health and healthcare disparities, and it requires that we value everyone equally, that we address, as was mentioned, the avoidable inequalities, that we provide supports that are proportional to the needs, and that we remove barriers to optimal health. And I think you've seen graphics like this before. This one I like because it adds in that third column where you just remove the fence altogether. Okay, so other definitions that are important. Minority health. So there is a difference between minority health and health disparities research and work. Minority health refers to the sort of distinct health characteristics and attributes of racial and ethnic minority groups. Those groups are defined by the US Office of Management and Budget. OMB determines what the racial categories in the US are. So that's what the government follows. And minority health often focuses on the socially disadvantaged groups in part because of the groups being subject to potential discriminatory acts. And then minority health research then is the scientific investigation of those distinctive health characteristics that you find within racial ethnic minority groups and groups who tend to be underrepresented in biomedical research. And the goal is to understand health outcomes in these populations. Okay, and I was happy to hear social determinants of health mentioned. This is a busy slide. I tend not to like too many words on a slide, but this one's busy to give you lots of examples of what we mean by another key phrase, and that is the social determinants of health, which are conditions in the environment in which people are born, live, learn, work, play, worship, and age. So it's a lifespan approach that affects a wide range of health, functioning, and quality of life outcomes and risks. So the conditions, which might be social, economic, or physical, in the various environments, or the various settings, and the settings might be your neighborhood, your workplace, your school. These are important as factors, as well as things like social engagement, a sense of security, and well-being. They make a difference in terms of health. And so resources that can enhance quality of life can have a significant influence on population health outcomes. And examples are those that you see here. And we often think about them in broad categories of the social determinants that are individual level and structural factors. And one point I would like to make is many times when people talk about health disparities, the contributors to poor minority health, they talk about things at the individual level. So they talk about, well, you know, the groups, even just trust is an individual level variable, although it actually may be brought up to the community level in some sense. But you think about, well, the person doesn't have insurance, or the person doesn't have many years of education, or the person is non-compliant with their medication, things like that that are individual level. And without factoring in the really influential and often beyond individual control social determinants that are structural factors. So these are the things that are upstream determinants of health. That might be policy, that might be health system factors, that might be interpersonal factors, community level factors that influence individual outcomes and behavior. So I always encourage individuals to really think about, so that we don't fall into the trap of kind of blaming the victims in some sense. Okay, so in May of this year, NIMHD launched a toolkit of measures to assess the social determinants of health in research context. So if you're interested in incorporating these kinds of constructs into your research, this would be one tool that you could utilize. It's part of the Phoenix toolkit. It's a special social determinants of health protocol collection that we launched. And this was a culmination of a process that required over a year in collaboration among NIMHD, the National Human Genome Research Institute, and a trans NIH and external scientific Phoenix work group, and it added 19 constructs into this special collection. And so we are encouraging applicants for grants and even researchers writing papers with human subjects are really encouraged to incorporate a minimum. What we have in the collection is our core one sort of tier measures that we think all the studies should collect, and then the tier 2 measures. And we're still working on creating specialty collections so that if you're interested in studying neighborhood level factors or individual level factors, you have a place to go to find what are valid tools that we can use to assess these constructs. Okay, so when did the science of health disparities really gain traction and why? Okay, so the short story here is that the Task Force on Black and Minority Health was established by the Secretary of Health and Human Services. At the time, her name was Margaret Heckler. And this was in response to the striking health differences between many racial minority populations in the United States compared to the majority population. So Mrs. Heckler noted that the health and longevity of all Americans had continued to improve, but that the prospects for living full and healthy lives were not shared equally by many racial ethnic minority Americans. And so the most striking differences was the gap of more than 5 years in life expectancy between African Americans and whites, and the infant mortality rate for which African Americans was twice that of whites. So Mrs. Heckler then created a special secretarial task force to investigate these discrepancies. And this is also when the Office of Minority Health, which still exists, was implemented it was established to implement the recommendation of the task force. So this was really significant time point and measure towards developing a coordinated all-hands government strategy to improve the health of all, including racial ethnic minority groups in particular. And so, after the initial review of the data, the task force adopted a study approach based on the statistical technique of excess deaths. And that is to define the differences in minority health in relation to non-minority health. And this method dramatically demonstrated the number of deaths among racial ethnic minorities that would not have occurred had mortality rates for minority individuals equaled those for non-minorities. And I don't even like the term. I'm using these terms because these are the terms in the language at that time. We've since evolved and we don't often say non-minorities and just minorities, but just for keeping it consistent with the time point. And the analysis of the excess death revealed that 6 specific health areas accounted for more than 80% of the higher annual proportion of racial ethnic minority deaths, and these are listed here. So at that time, and what's interesting about that when you think about progress, what's happened in this 35-year period, for many of these things, we're still having the same significant disparities. And one that has a lot of attention more recently as an example is infant mortality. Okay, so NIMHD, the youngest NIH institute, and as I mentioned, we are celebrating our 10th anniversary. The institute was a center for 10 years before it became an institute, and an office at first for 10 years before that. So we've come a long way. And our mission is to work across NIH and the Department of Health and Human Services more generally to advance the science of health disparities and to move us closer to meaningful progress. Because as I mentioned, in the 35 years since the Heckler report, we still have health disparities. So these are the NIH designated US quote unquote health disparity populations. And so you see those that are listed here. It also includes, in addition to racial ethnic group, individuals who are socioeconomically disadvantaged in general, and also underserved rural populations, and also sexual and gender minorities. And so when you think about my earlier question about what the contributing factors are to health disparities, it's complicated. And their health disparities are the result of differences in and the interplay among numerous determinants of health. And those include those that you see here and probably others. And when I made this figure, the blue box, the blue circle at the bottom represents the broad categories of social, economic, cultural, and health system factors. And most of the research says that these are the main direct causes of health disparities. The other boxes are sized in magnitude based on the extent of evidence in the literature. So we know that inequities in social determinants of health and demographics directly impact health disparities. We know that discrimination, both in healthcare systems, also directly influence health disparities. And then these things are also interacting with each other. So I also wanted to introduce you to, if you have not already seen it, the NIMHD Minority Health and Health Disparities Research Framework. This framework was 2018 published. It's a process that lasted years before that. It reflects an evolving and a conceptualization of factors relevant to how we understand and promote minority health and how we conduct science to understanding how to reduce health disparities. So the framework is really a vehicle for encouraging NIMHD and NIH-supported research in general that addresses the complexities and the multifaceted nature of minority health and health disparities. So this includes research that spans different domains of influence. And the domains are biological, behavioral, physical, built environment, healthcare system, et cetera. And also it considers the levels of influence. So it's beyond that individual level. We also have to consider what are the interpersonal factors at play here, what are the community, and what are the societal factors within these domains. So when we study health disparities, we're looking for measurable outcomes. So these include whether a population experiences a number of things, such as higher incidence, prevalence, including maybe earlier onset or more aggressive disease, premature or excessive mortality from disease, greater global burden as indicated by various population health measures. We also think about poor health outcomes and health behaviors. And then also we think about worse outcomes that reflect daily functioning or symptoms from specific conditions. So, you know, in the 35 years since the Heckler report was published, there has been some progress, which is always important to highlight. And I don't have all the things here that demonstrate what has happened since then. But I think thanks to the efforts of researchers, advocates, other stakeholders, that gap in mortality between Black Americans and white Americans was reduced by about half between 1999 to 2005, narrowing from about 33% to 16%. And not all health outcomes are worse for populations that experience health disparities in selected conditions. And then also there are certain conditions where racial ethnic minorities of less privileged socioeconomic status actually have better outcomes. And good examples of those would be, you might be familiar with the Hispanic paradox, as people call it, where individuals who are Hispanic Latino tend to have better health than white non-Hispanics. And, you know, there are lots of theories about why that might be true, but it might not be what you would expect. However, given that individuals comprising these groups still face considerable health disparities in most conditions, such as shorter life expectancy, you know, heart disease, cancer, diabetes, it's an area that we really need to continue to focus on in terms of study. And these are a few examples of persistent health disparities. So first, we know that race and ethnicity predict life expectancy and mortality in ways that are not fully explained by socioeconomic status. African Americans also have more strokes compared to white Americans. And also African Americans have more, actually, if you have hypertension and you're African American, there's a lower likelihood of heart attack, but more likelihood of cardiomyopathy, which is a different health condition. Among all people with diabetes, racial ethnic minorities tend to have less heart disease compared to whites. So we know that these factors, but it gets complicated, especially depending on the conditions that we're talking about. And more recent data looking at overall life expectancy, you know, show basically here that African-American males have the lowest life expectancy in the three groups that we see here, and Latino males have the longest, and the same pattern is observed among women. When we look at socioeconomic factors, we can see in this figure that there's a strong negative gradient in the risk of all-cause mortality in the US by annual household income level. These data were from 2016, and they show that the risk of death from any cause is 3 times greater among individuals whose household income is less than $25,000 per year. So income alone is independently related to life and death. So this is a policy group. What's the role of policy in law and policy in law and the science of health disparities? So I'll give you a few key examples that you should be aware of. So one is The first one is section 10334 of Public Law 111 through 148. And this is the law that tasks NIMHD with coordinating NIH's research related to minority health and health disparities. So in this law, the language specifies that the director of the institute, as the primary federal official with responsibility for coordinating all research activities conducted or supported by NIH and NIMHD, and that the director should be the person responsible for planning, coordinating, reviewing, evaluating research supported by NIH. The next law, section 2038 of Public Law 114 through 255, this is part of the 21st Century Cures Act, and this is the law that tasks NIMHD with fostering partnerships, collaborative projects related to minority health and health disparities science. And once again, the law says that the director of the institute may foster partnerships between various research institutes and centers, and should be encouraging the funding of collaborative research projects related to this topic. And then the last one here, Public Law 114 through 255, this in section 2031 indicates that the directors of NIMHD and the director for the Office of Research on Women's Health are to ensure that the plans account for the unique perspectives, strengths, and challenges facing minorities and women across the entire NIH. I'll give you one more example of how policy really helps move things along. This is, so in October 2016, sexual and gender minorities were formally designated as one of the health disparity populations for research purposes. And in the last example here, section 404N of the 21st Century Act encourages increased research on sexual and gender minority populations, noting mounting evidence of health disparities in these populations, as well as acknowledging that there are unique health challenges faced by sexual and gender minority individuals that may be affected by being in a socially disadvantaged position. And basic and clinical scientists who are interested in studying health disparities, for instance, within genetic science and genomics, often include the concept of race to measure human biological difference. And the concern is that this perpetuates a false belief by some people that differences in disease outcomes stem primarily from inherent pathophysiological differences between what are social categories, because race is a social, not a biological construct. And researchers and community leaders have raised concern that the consequences of us relying, or the scientists who do so, relying on the biology of race are many, and include that they may lead to the promotion of eugenics, which I think this group has had to talk about, misattributions about health and health disparities. It also may be what has not led us to have much progress. And this results in sort of deficit models, thinking about what's wrong with people, and also reductionist approaches, reducing people to a set of genes, or for example, a set of biological factors. And this prevents us, according to many researchers, from considering the roles of the upstream determinants of health and of life expectancy. So coming back to COVID-19 as an example, that's timely and major. There are two possibilities for racial and ethnic disparities in COVID-19 cases and outcomes. And medical comorbidities is what you hear most often from scientists, physicians, and health officials. Racial ethnic minorities have a disproportionate burden, as we know, of underlying comorbidities. So using the example on racial disparities in COVID-19, a simple conclusion would be the possibility that genetic or other biological factors may predispose racial ethnic minorities to more severe disease and higher mortality, and that, perhaps African American, Hispanic, and American Indian populations might even need special vaccines or therapeutics to eliminate disparities in COVID infection rates and outcomes. The problem with this explanation, among several other problems, is it's absent the full context of the pandemic. Any of these explanations must be considered in the full context of the systemic and structural factors, such as historical and ongoing discrimination, the role of chronic stress and its impact on immunologic functioning and health. And indeed, there is evidence linking stress related to racial discrimination to increased risk of these chronic health conditions and negative health outcomes. So we have to look deeper And only when we kind of utilize a critical, level of analysis is when we can use this kind of window of opportunity that we have in front of us to understand the primary causes of health disparities. If we don't do that, we might fail to realize the breadth of factors that drive disparities, and we may preclude ourselves from learning from past mistakes, and it could even lead to harmful policy solutions. So this is a model that I developed to help me think about factors that contribute directly to COVID-19 cases and outcomes. And the model is based really on what we found from the early signals about what's happening, and also what we know about why health disparities more broadly exist. And these factors can be themed as related to health and healthcare, socioeconomic factors, and also the social determinants of health. Now, also illustrated on this figure is this backdrop of systemic racism and discrimination, which directly affect health, as we know. And we also have similar observations when it comes to COVID-19, transmission, infection, and death. So the point I think here is that this is not about what we're observing in COVID-19 and other health disparities because of inherent susceptibility differences, but because of social inequities that have led to more pre-existing conditions like heart disease, diabetes, and HIV. And there are many examples of that, but I think it's important because otherwise what we would be suggesting is that, all racial ethnic minority groups are inherently different. And we know that that's not true. The huge human genome research project showed us that 99.9% of us all have the same genetic code. And that small variation exists, and it results in population differences that are led not by a social category, but by, for example, geographic location or family linkages. So myself and the director of our institute, Dr. Eliseo Perez Estable, and Ana Napoles, who is our scientific director, we wrote an article that we published in JAMA Viewpoint in May. So right as this was starting, and I think the goal of this paper was really to talk about what we were seeing at that point, which unfortunately has not changed, about the greater prevalence of cases and mortality in various populations. And we, in that article, really kind of set the stage for what we think would be important research efforts to understand the underlying causes of this burden and the need for prevention, healthcare designed to address these problems. So I'll just tell you one major initiative, and then I will stop, and perhaps we have a few minutes to discuss. I'll tell you about one initiative that NIH is working on in terms of health disparities research in COVID-19, because the question could be, what is NIH doing about all this? The good news is that we are working really hard, and we have been since the pandemic started. We've got several significant initiatives going. So I'll describe one of them. It's known as the Rapid Acceleration of Diagnostics Underserved Populations, or RADx-UP. And it is really focused on deploying emergency grants, highlighting this need to address the pandemic and the disparities that are observed. And the way this came about was the NIH Office of the Director received a $1 billion congressional appropriation to study COVID-19 testing, specifically to develop, validate, improve, and implement testing and associated technologies, and to accelerate research, development, and implementation at the point of care, and also other kinds of tests. So this initiative is known as RADx, and there are 4 components of RADx. RADx-UP is among them, but this is really one of the major scientific responses to the pandemic. The other one is Operation Warp Speed, which is the vaccine effort. So the identification of strategies to increase testing and the uptake of testing is important when we think about the larger public health picture, the larger population health picture, that as we try to identify hotspots, slow the spread, treat people, isolate them, and move this forward. And so this kind of work is important for making sure that testing reaches populations who have increased risk of infection, poor outcomes, and mortality. So with the $1 billion that the Office of the Director received from Congress, they committed $500 million. So Francis Collins decided that $500 million would go towards RADx-UP. So it's more than the other RADx initiatives. And the goal is to focus on testing specifically in vulnerable and underserved populations. So it's called RADx Underserved Populations for that point. And I think it's also noteworthy that this is, to my knowledge, the largest NIH investment in health disparities research for a single initiative. And so we've just completed the first reviews and the first announcements across the country of RADx Up grantees will be announced probably within the next week. And we're hoping that these projects really get underway quickly. The priority populations are those that are underserved, as well as those who are COVID-19 vulnerable due to medical, geographic, and social factors. And so underserved is our disparities populations. And the funding opportunity announcements have a very long list of populations that we know are at increased risk. And so those are the groups that we're focusing on for RADx Up. And briefly, it includes 4 funding opportunities for the first announcement. And essentially, it's all about ensuring that testing, repeat testing, contact tracing reaches the groups with additional risks. So this will be a consortium of about 30 to start. It'll be about 60 in about 6 or 7 months. But the first group is about 30 community engaged research projects that are all focused on this effort. The projects will also focus on the social, ethical, and behavioral implications of testing in under-resourced groups. So what happens when you test underserved groups? What are the next steps, especially among individuals who may not have the privilege of being able to self-isolate? How do we make sure that patients interpret their test results correctly? This effort will also start to look at thoughts about vaccine implementation and concerns and how to get ahead of them. Critically, what we're really interested in is community engagement. Too few studies include the populations affected in their development and implementation. And as a result, we have these sort of acontextually developed interventions that may end up largely benefiting health outcomes in one sector of society while inadvertently creating, sustaining, or increasing health disparities in another. And this can perpetuate health disparities by kind of ignoring those really keen insider insights and perspectives that community members and leaders offer. So addressing this in a meaningful way is part of the treatment, if you will, and how we move forward in this science. So we are asking that the grantees really show us evidence of academic community partnerships that are equitable and that can lead to shared decision-making, co-learning, co-sharing. And it's sort of a transformative process, I think, if we can do this successfully, to transform traditional research approaches where participants and partners can feel used and at the mercy of researchers, to a more active opportunity to work with researchers as equal partners in developing interventions for the greater good of all people in the country. And I want to tell you one other thing. This might be of interest about the Health Disparities Research Institute, or HDRI. So HDRI fits within the training mission of NIMHD, and we aim to support the research career development of promising early career minority health and health disparities research scientists, and to stimulate research in the discipline supported by health disparities science. So HDRI has a program, and it happens every August. It features lectures on minority health, health disparities, research, small group discussions. You would participate in a mock grant review, seminars. Participants have the opportunity to meet with NIH scientific staff who are engaged in these projects. And the seminar from the 2020 HDRI covered the etiology of health disparities, methods and measurement, and intervention and implementation research. Participants also receive consultation on how to develop their research interest into an application, like an R21, an R01, a K award, as well as consultation on research strategies and methods for proposed studies. And the HDRI is intended for applicants with a doctoral degree, PhD, MD, DO, Doctor of Sociology, PharmDs, et cetera, Doctor of Public Health, or and also we're interested in early career, early stage investigators who've completed their degree, their terminal degree within the past 10 years. So we're looking for assistant professors, postdocs, early stage investigators. And we also are looking for individuals who have plans to submit a grant, a K grant or an R grant within the next 12 months. And the 2020 HDRI was held virtually. It's usually in person. It's a week. It's a full 5 days. This is a summary that just gives you an indication of the competitiveness of the program. So this year we had 224 applications, 66 were selected, and they represented across the country, 24 states, DC and Puerto Rico. These are the attendees, and this was really cool picture because it was virtually, so we didn't have a chance to have the group picture, but we're able to sort of spliced all their individual pictures together to come up with a really nice representation of our attendees at this year's Institute. And the cohorts are typically racial and ethnically diverse. Last year, most participants identified as African American, followed by white, Latino, Asian, etc. They were mostly women, mostly PhDs, and mostly assistant professors. So, and I pulled this from our science policy group in preparation to talk to you. And just to give you a sense that, NIMHD supports policy related projects. So this just shows that, over a 2-year, 3-year fiscal year period, that almost 10% of our budget goes to projects that have policy relatedness to them. And so we support a number of projects. And then when you think about our cumulative budget, it ends up being almost 10%. And this is probably an underestimate, but these are projects that specifically have a really clear policy goal. So for example, we fund projects one that's looking at the statewide implementation and evaluation of a rural school-based cavities prevention program. They have a tie to health. So another one that focused on improving minority health and monitoring Medicaid quality disparities. And one other example was a project assessing jails' use of community-based emergency care in the United States South. So we are interested in funding this type of work. And the last thing I'll mention is that if you want more information about the study of health disparities, strategies to study it from multiple levels, then I refer you to the special issue that was published in early 2019, which has our health disparities framework. It has definitions. It's got over 30 research strategies and how you can do this work. And this came together as a multi-year process as well that includes academic scientists and also staff at NIH and NIMHD. So I will stop there, and thank you so much for your attention. I'm happy to answer any questions that you might have.
Great, thank you very much for that talk. So if you guys have questions, feel free to just unmute yourself and ask them, or if you would rather just send them in the chat, and I'll get to them and work the chat for you, Dr. Hooper, so you don't have to focus on that.
Okay.
Yeah, I have a question. Thank you so much. That was a fantastic talk. So COVID's been moving really fast, and there's a ton of new researchers trying to jump in on COVID research, of course, including the health disparities issue. And I know there's been potentially a lot of preprints being released, and there's been concern that some of these researchers use the biological construct of race because they're not experienced in that field. And not familiar with the field and how to perform this research. I'm wondering if you're familiar with whether this research that has exacerbated racial disparities in COVID, or if NIH has done anything to address kind of this, how people are researching the racial disparities, especially with COVID, since it's such a fast-paced field.
So this is a really good question. And actually what you mentioned is something that I'm concerned about. I have seen the same thing that if you go to PubMed and you search, I mean, the thousands of articles that are already showing up in COVID in a 6-month period. I mean, I don't know this, but it has to be unprecedented. I mean, the amount of research that's being churned out, and I think it is so fast and it may not be particularly thoughtful. I think that we all have to be very careful with when we are studying a basic science construct or even a clinical science construct, and we are talking about race. The problem with much of that work is that there's failure it's just to say, okay, this group has a greater prevalence of this illness without anything about the upstream determinants. None of that is factored into their analyses. Many times people don't even know how to assess those things, or they're generating it from, fresh frozen tissue or from the EHR, things that would make it a little bit more complicated for them to think about, and they often don't. So is there a systematic effort by NIH to address using race as a research construct? Not in the basic sciences that I'm aware of, but it could be happening and I'm not aware of it. We certainly at NIMHD always discuss this, and we encourage people. I mean, the problem Well, there's a number of problems, but I think one is that it's actually quite disappointing that we have to have an institute focus on this topic, right? That we have to have research focus on this topic, because it is a social construct and it's something that should be meaningless to us. But unfortunately, it's not. And it has a major impact on people's lives, but not because of the biology of it. It's because of what happens socially, because of your identification of a racial group, and even more importantly than that, how other people perceive you and what racial category they would put you in. So it's something that we talk about every opportunity that we get, and we will continue to try to talk about it and encourage people to do that. I've also seen some editorials published, not necessarily from NIH, but from other scientists really criticizing and being concerned that, you know, we'll have the opposite effect that we want in terms of addressing these disparities and fall deeper in to thinking about race as a biological construct. So we're thinking about it and trying to address it.
Thank you.
I have a question for you guys then. So how do the things I've shared fit in with the 3 previous presentations you've had as part of your webinar series?
So I would say this has been pretty good. Our first talk was more on, it was, I guess, like the past, and it talked more about eugenics and like the history of the university and Virginia and its role in eugenics. And I think it relates to like how these issues sort of began or continue to go throughout time and thread through. And you know, like in how we still haven't really like addressed these issues, and they still sort of come up in different forms. The other talk we had was about like environmental sciences, really more related to that, and like how I would say like how we address like environmental justice and what issues those have on like minority communities in particular. And I think it's related certainly to like all the health disparities in terms of like where like and the issues that exacerbate that, and like how like where you live, what your job is, what your money is, how much money you make, how that can affect your health and everything like that. But I think this is really this was a really great talk, and bringing sort of like these topics together, and giving us a really good like foundational understanding of health disparities and how we're trying to address them now, and how COVID has really just made it a huge problem, and it like definitely just made it worse. Anyone else who's also been to some of these talks, feel free to share your opinions.
I think it also ties into this overarching problem we're addressing with this series, which is that we don't have a formal education in how my work as an environmental engineer impacts racial disparities, and how, I mean, we might have people in the sociology department over there, you know, yelling about it in the African American Studies department who already know this, but we don't know it as engineers. We haven't learned it. So I think seeing the formal analysis that you presented, the specific pieces that you include in your studies is incredibly helpful and kind of understandable as an engineer too.
Good, thank you for saying that. You know, and I think you're right. In certain departments, you have more formal training in health disparities. But what I've noted is that people who study health disparities, even other behavioral scientists, they often were not sort of trained in it. I think there might be 1 or 2 departments, maybe a few more now in the country, who have a degree that's sort of more focused on health disparities. But at first, it wasn't even necessarily considered a rigorous science. I mean, the science of health disparities has improved in terms of its rigor. At first, it was sort of just viewed as community outreach and kind of put over there. And gradually, it's gained more traction as an actual science and area of study. And it's not one area because it crosses so many different sectors and domains where you can find examples of health disparities. And so certainly, from what I've seen across disciplines, is if you really think about it, the work may exacerbate or sustain disparities. And so it's important to, I think, bake that into what you're thinking about in the beginning is how will this affect people? How will this affect people? How will it have a differential effect on people? And of course, we want to minimize any potential negative consequences. Sometimes, of course, like with policies, you have unintended consequences. They didn't realize it would happen that way. And then that's what's happened over time. But more and more, I think we're just trying to encourage people to think ahead. And if you bake in the issues around equity in the beginning, then maybe we'll have more success with moving forward, because progress has been slow. It's not been as quickly as we'd like to see it.
I have a question about maybe how your organization is looking at research in general and how to move it from an individual focused body of work to more structural. And I think what really comes to mind for me is the incredible amount of research that's done on implicit bias. Not that it isn't important, but that is a body of research that's really focused on individuals versus structures. And are you thinking about that and putting in structures to sort of move us above that level?
That's a really great question and observation. And yes, the answer is we are thinking about that. At our most recent advisory council, for each institute has advisory councils 3 times a year. And the advisory councils for NIH really help us move forward concepts that we're thinking about to help move the field forward in a particular area of research. And so we have a concept that has just been approved by our council in early September that will be published probably later this year, that is focused on structural racism and discrimination in health. And the goal of it is to move us beyond thinking about how, for example, structural discrimination affects people individually, but how do we impact these structures? How do we impact systems, whether it's a health system, a neighborhood level factor, police systems? There could be many different systems to think about, but certainly we're trying to encourage more people to do that. I think it's going to require people not only thinking outside the box, but really creating a different box, a whole new box to think about how to address these problems, because it's not the way we've thought about it. Even in this work, it generally is, how do we change people? How do we change these under-resourced people? How do we change these minorities and help them come forward? And I think that thinking has facilitated some of the problems that we have. And particularly if the thinking is, well, how do we just prescribe a different medication? Let's just find the gene and, give them a different medication. That's the wrong way. And that's why we haven't gotten anywhere, because that just doesn't work.
I guess I have a question. So I think in our series we've been talking and in these talks our focus has been to sort of educate ourselves and re-evaluate what we know about sort of disparities and how they're related to science policy. But I guess what do you think we can be doing beyond educating ourselves? So we not as a semi-professional organization, we both have seminars and do things like that and just learn and read. But what actions as I'm a graduate student in chemistry, so I don't deal with humans too often or anything like that. And I'm interested in science policy, but what do you think as an organization, as graduate students even, what more can we do to help? Because I feel like a lot of these problems are very complicated and it can feel overwhelming at times, especially now. How does a sort of more educated individual is learning more about this? What is your suggestion for how we can make the world better in our own individual way, I guess?
That's a really good question, and it's not the simplest to answer.
Right.
I mean, I think that all of us have a domain of influence, right? So you can think about how can I have an impact on this? And I know we're at time, so I'll make this quick.
Sorry, yeah.
How can I have an impact personally as an individual? I want to see things better. So that's more of the, what can I do in my own life? And that might be helping educate your friends, helping talk to your family members, helping, at that level. It might be joining an advocacy organization, not necessarily protesting in the street, but it just might be helping an advocacy organization who's working on a policy issue that's important to you. or that you want to make sure that organizations working on policy are thinking about issues around equity. So it could be something like that you do in your volunteer in your own time. If it's something more about your research, it could be, when you start with your research ideas, or as you're moving forward with the ideas as early as possible in the process, that you are thinking about, especially if it's a health related project, what are the implications of my work for health equity? Do I think that there's any potential for my project to have a disparate impact on populations that are already disadvantaged? And if so, how might I revise my design, or how might I conduct analyses to actually understand if that's true or not? Because that could be part of the scientific question. Depends on what it is that you're studying. But I think the education is the first step, and just being aware and cognizant of the issues, and then thinking about how I can apply it both personally and professionally. And I think we all have work to do, because the bottom line, she mentioned implicit bias training. The bottom line is we all have biases. We all do. Period. And there's just kind of no way around it. That's how it works. It's what do we do with that information? How do we acknowledge the biases we have? And how do we make sure that it doesn't impact us as much as we can? And we should just be aware of that. And, I'm a psychologist too, so I've done a lot of thinking and talking with people and treating people around these various topics. And it's not easy, but, people are capable of change. Otherwise, there'd be no need for psychologists and therapy. People can change if they want to change, but they do have to see a reason to change and understand that there is even an issue. What's good about this time point in our country is that there are more people than before thinking, oh, maybe there is an opportunity for change here. And just having that conversation in an open way now is, I think, an important first step, and much more helpful. We're talking about things at work and at school that we just didn't talk about before. So I always have to extend grace to people, because people, may not know the right terminology and all the various things that might get in the way of them wanting to say anything. And I think we have to extend grace as everyone is trying to grapple with what's happening.
Great. That was a great answer for a complicated problem and question. Thank you very much for coming in and taking your time out of your busy schedule, and obviously very complicated problems that you're dealing with in your institute. We really appreciate it, and we really appreciate the opportunity for recording this, so that we can let other people know, let other people who couldn't make it be a part of this and hear about this and educate on this. And thank you so much.
Thank you. Thanks for the thumbs up and the claps. I see them and I appreciate it. You guys take care, and best wishes on your studies and beyond.
All right. Thank you.
Welcome. Bye, Carter.
Thank you.